Hello everyone. So today we'll discuss about all the important ECGs that has been asked and that has the probability to get asked in upcoming NEET PG and INICET exam. So stay with me till the end of the video. And अगर अभी तक आपको थोड़ा सा भी ऐसा डाउट था कि आपका ECG स्ट्रांग नहीं है या आपके ECGs के क्वेश्चन नहीं होते, so I'll make sure definitely कि till the end of this video we'll definitely grasp have a good grasp on ECG and you will definitely be able to solve the question on ECG. So let us start this discussion. फर्स्ट ऑफ ऑल एक नॉर्मल ईसीजी में हम क्या क्या चीजें देखते हैं उसी के अकॉर्डिंगली विल डिस्कस द abnormality. तो एक नॉर्मल ईसीजी में व्हाट वी सी इज रेट, रिदम, सिस, पी वेव, पी आर इंटरवल, क्यू आर एस, एस टी सेगमेंट, क्यू टी इंटरवल and T wave. Okay, so we'll look at these things in an ECG. Okay, so let us start from rate. So rate की abnormalities क्या हो सकती है? If rate is more than 100, then it is tachyarrhythmia. If rate is less than 60, then it is bradyarrhythmia. So tachyarrhythmias in itself are very important, and we will discuss tachyarrhythmias in the end of this video. Bradyarrhythmias we will discuss in PR segment या PR interval वाले topic. And another important thing is how to calculate the rate in an ECG. So rate is 300 by RR interval in terms of big squares. Okay. So suppose if RR interval in term of big squares is 2 big squares. Okay. Then rate is 300 by 2. It is 150. Okay. Why we take RR interval? Because starting from one QRS to another QRS, one cardiac cycle completes. Okay. Now after rate, we have this abnormalities of rhythm. Okay, so rhythm can be regular, which is normal, and rhythm can be irregular. Okay, so irregular rhythm ECG में कैसे पता लगेगा? That RR interval differs. Suppose one RR interval is 3 big squares, another RR interval is 2 big squares. Okay, so that is an irregular rhythm. And the causes of irregular rhythm in ECG is atrial fibrillation, atrial flutter, third is MAT, that is multifocal atrial tachycardia. Okay, now let us discuss about these three first. Okay, so this first is a ECG of atrial fibrillation. Second is an ECG of atrial flutter. Third is a ECG of multifocal atrial tachycardia. We can see RR interval variable है सब में, है ना? That is irregularly irregular rhythm है here also. Okay. Now इन तीनों में कैसे differentiate करेंगे? तो ECG देख के हमें तो पता लग जाएगा कि rhythm is irregularly irregular. That means it is either atrial fibrillation or flutter or multifocal atrial tachycardia. So atrial fibrillation में कोई visible P waves ही नहीं होंगी. So first ECG में आपको P wave कहीं नहीं दिखी. So this is atrial fibrillation. Second ECG में we have sawtooth like P waves. Okay, so this is a P wave, this is a P wave, this is a P wave, P wave, P wave, P wave. So we have a sawtooth like P wave in atrial flutter. And in multifocal atrial tachycardia, we have one P wave before every QRS, but there are three or more than three different morphologies of P wave. Like here we have one morphology, another morphology, another morphology. So this is multifocal atrial tachycardia. Okay. Now after the abnormalities of rhythm, third thing to look is axis. So axis can be normal, can be right axis, can be left axis, and can be extreme axis deviation. तो इसको कैसे देखेंगे? For axis we use two leads. This is lead 1 and this is lead AVF. Now in ECG अगर lead 1 में QRS upright है and AVF में upright है, then axis is normal. Okay. Lead 1 में अगर upright है, AVF में downward है, then axis will be left axis deviation. Okay. Lead 1 में अगर downward है and AVF में upward है, then this is right axis deviation. Okay. And lead 1 में अगर downward है and AVF में भी downward है, then we have this northwest axis. Details में I have already discussed it in the video of basics of ECG. And what is the normal axis? Normal axis is -30 to +100. Okay. After axis, we'll look for P wave. Okay. So what is a normal P wave? This in lead 2 we'll look for a P wave in lead 2 and lead V1. Okay. So the normal P wave in lead 2 is less than 2.5 mm width and less than 2.5 mm height. Okay. And in V1 lead P wave is biphasic and both upright and downward deflection is less than 1 mm. Now if there is broad P wave, that is width is more than 2.5 mm, height is still less than 2.5 mm, then it is P mitral. If P wave is tall, it is more than 2.5 mm height, then it is P pulmonale. P pulmonale is because of RA enlargement and P mitral is because of LA enlargement. And why the name? Because the most common cause of LA enlargement is mitral valve involvement and most common cause of RA enlargement is pulmonary artery hypertension. So here we can clearly see this is P pulmonale. Why? Because although the width is normal, the height is almost 4 mm or 4 small squares. This is P mitral because width is almost 4 mm or 4 small squares. Okay? So this is the ECG of P pulmonale. This is the ECG of P mitral. Trust me, multiple times the question has been asked like this. Suppose they give you a strip like this and they can ask you what is shown in the ECG and they can give options like P pulmonale, P mitral, normal P wave. Okay. Then we'll come to PR segment. PR interval. Okay. So what is PR interval? PR interval is P wave plus PR segment. Okay. And normal PR interval is less than 5 mm. Now PR interval की abnormalities can be also it can be prolonged PR that is more than 5 mm or shortened PR that is less than 2.5 mm. Okay. So the causes of prolonged PR are AB blocks. The types of AB blocks are first degree, second degree, and third degree. We have already discussed them, so we will not discuss it here. And the causes of short PR is WPW syndrome. So in WPW syndrome, we have accessory pathway. So AB nodal block या delay जो हो रहा था वो नहीं होगा. And there will be accessory pathway जिसकी वजह से there is a delta wave in QRS like this. And this question has already been asked multiple times. So you can see there is shortened PR. After P wave, there is a very small PR segment. Also, there is this delta wave. Okay, so this is an ECG of WPW syndrome. This is again an important ECG. Then abnormalities of QRS. The normal QRS is 0.12 milliseconds or 3 small squares. Okay, now the abnormality of QRS is broad QRS. And the causes of broad QRS is one is bundle branch block, another one is ventricular ectopics or VT. Okay, so this component we'll discuss in arrhythmias, tachyarrhythmias. Now let us discuss bundle branch block. So normally V1 may we have this RS pattern and in V6 we have this QR pattern and the duration is less than 3 small squares or less than 0.12. Now in right bundle branch in V1 we have this RS R dash pattern or we also call it as M pattern. And in V6, we have this QRS pattern, also known as W pattern. Okay, so M in V1 and W in V6 presents RBBB. In LBBB, we have this W pattern in V1, or sometimes there is just a V pattern in V1, that is a downward wave, and this M pattern again, or RSR dash pattern in V6. Again, the QRS will be brought here. The duration of QRS would be more than 120 milliseconds. Okay. So in this CCG, again, we can see the QRS is broad. The duration of QRS is 4 small squares. Okay. So the duration is 4 small square. So it is 0.16 milliseconds. Also, we can see we have this V pattern in V1 and M pattern in V6. So this is a ECG of left bundle branch block. Also, we can see that in lead 1, QRS is upright, and lead 3 or lead AVF, QRS is downward. So this is left axis deviation with left bundle branch block. Okay. Now again in this ECG you can see QRS is broad. It is almost 3.5 small squares. Okay. And we have this M pattern in V1 and W pattern in V6. So this is an ECG of RVP. And one important thing to note is कि आपको V1 V6 में किसी एक में भी पैटर्न मिल जाता है, then it represents dead bundle branch block. Okay, suppose यहाँ पे M pattern मिल रहा है, although here we have a W pattern, small downward then upward then downward, but कभी कभी नहीं भी मिलता, but एक लीड में मिल जाता है, then it is dead bundle branch block. Okay. Now the another abnormality of QRS is hypertrophy, ventricular hypertrophy. Okay, so normally in V1 we have this RS pattern, and in V6 we have this QR pattern. And normally LV is 3 times thicker than RV. Now suppose अब LV और thick हो गया, then we call it as LVH. तो LVH में क्या होगा कि नॉर्मल पैटर्न ही रहेगा, क्योंकि नॉर्मली भी LV इज थिकर देन RV, बट ये नॉर्मल पैटर्न एक्सेगरेट हो जाएगा. डेट इज V1 में बहुत ही डीपर एस वेव्स हो जाएंगी, एंड V6 में बहुत ही टॉलर R वेव्स हो जाएंगी. एंड द क्राइटेरिया इज S in V1 plus R in V5/V6. If more than or equals to 35 mm or 35 small square, then it is LVH. Okay. Similarly, in RVH, now the other chamber is thicker. That is normally always thicker. In RVH, we have thicker RV. So normally जो V1 में small R and a deep S wave मिल रही है, pattern reverse हो जाएगा. So we have small Q wave in V1 and a big R wave in V1. The criteria is that either R to S ratio in V1 is more than 1, or isolated R wave in V1 is more than equals to 7, then it fulfills the criteria of RVH. Okay. Similarly, in this ECG, we can see that we have a deep S wave in V1 and a tall R wave in V6, and it is almost 30 mm here and 25 mm here. So total is 55 mm. Definitely, it is more than equals to 35 mm. So this is an ECG of LVH. Here also we can see V1 में normally we see this kind of pattern, that is RS pattern. Here we have a QR pattern in V1, and in V1 the R wave is almost 15 mm. So it is more than equals to 7 mm. So this is an ECG of RVH. After QRS, we have ST segment. Okay. So in ST segment, we'll look for elevations or depression. Now the elevations, ST segment elevation can be seen in a lot of conditions, but for us the important things are STEMI and pericarditis. Why? Because both of these will be having chest pain, although the character of chest pain will be different. So now you will tell me in the comment section that how can you differentiate between the pain of a STEMI and the pain of a pericarditis, because there are multiple causes of ST elevation, but pain nahi hoga, so we will not get confused between STEMI and that particular cause. But in pericarditis, again, the pain would be there. Okay. Now, this kind of ST elevation, in which the ST segment elevates in a obliquely straight way, is mostly represents STEMI. Also in STEMI, we have reciprocal depressions. Okay. In reciprocal leads. In pericarditis, we have these type of concave ST elevations. So these type of concave ST elevations can be seen in pericarditis or early repolarization syndromes. Okay. These type of convex ST elevations are again seen in STEMI. These are more typical of STEMI. And in STEMI, we can also see these reciprocal depressions, while in pericarditis, we have this PR depression. As in this ECG, you can see these are convex type of ST elevations in lead 2, 3, and AVF. Okay. So now we have elevations in lead 2, 3, and AVF. That is, it means it is an inferior wall STEMI. And we can see these are reciprocal depressions in lead 1 AVL, V5, V3. Okay. So this is a case of inferior wall STEMI. Now, how to localize a wall? If we have ST elevation in lead 2, 3 AVF, then it represents inferior wall. Okay, because lead 2 is like this, 3 is like this, and AVF is like this. So these all are inferior wall. In lateral wall, we have lead 1 like this, lead AVL like this, and V5 and V6 also here. So 1 AVL, V5, and V6 represents lateral wall. V1, V2 mostly represent septal wall, and V3, V4 anterior wall. Okay, again the vessel. So in lateral wall, mostly the vessel involved is LCX, it is less left circumflex. In inferior wall, the vessel mostly involved is RCA, but sometimes it can again be LCX. In anterior wall or septal, vessel involved is LAD, left anterior descending artery. And the most common vessel involved in STEMI is LAD. That's why it is also known as Widower's vessel. Let us now discuss about QT interval. So first of all, what is QT interval? It includes QRS complex plus ST segment plus T wave. Okay, and why it is important? Because QT interval, when prolongs, it leads to the prolongation of relative refractive period, which is a dangerous period. So it can precipitate polymorphic VT, which is also known as torsades T point test. Okay, so we'll discuss about torsades T point test in tachyarrhythmias. Other than that, how can we calculate this QT interval? So we used to calculate this QTC, that is corrected QT interval. It is calculated using this formula QT by under root of RR interval. And if it is more than 0.44 in males or 0.46 in females, then we call it as prolonged QT. The causes of prolonged QT can be congenital long QT syndromes or acquired. In acquired, two important things are there. One is drugs. Other than that, electrolytes. And in electrolytes, we have all three hypo, that is hypomagnesemia, hypokalemia, and hypocalcemia. Okay. Now you'll tell me in the comment section that which three drugs are there which can cause prolonged QT. So multiple drugs can cause prolonged QT, but you have to tell me at least three drugs. Okay. Now after that we'll discuss about T waves. So T wave abnormalities can be tall T waves or T wave inversion. Out of them, tall T wave is important. So we'll discuss about tall T waves. So when T wave is more than 5 mm in lean leads or more than 10 mm in chest leads, then we call it as tall T waves. Other than that, if T wave is more than half of QRS height, then we call it as tall T waves. And the causes of tall T waves, two important causes. One is hyperkalemia. Other one is acute MI, hyperacute MI. Okay. So in this ECG, we can see that there are tall T waves in chest leads. Also, there is broad QRS. QRS here is almost 3.5 mm. And there are absent T waves. So this point towards hyperkalemia. Why? Because in hyperkalemia, we have tall T waves, then QRS broadens, P wave flattens, and in the end we have sine wave pattern. Okay. So after hyperkalemia, let us discuss about hypokalemia. So in hypokalemia, there is flattening of T wave. So here we can see that when potassium level decreases, there is flattening of T waves. There is appearance of U waves. P waves slightly become prominent, and in the end, T waves absent, and there is a prominent U wave. Okay. So in hypokalemia, we have two pseudo. That is pseudo QT prolongation. Why? Because T wave absent and U wave appears like a T wave, in which is a prolonged QU interval actually, but it appears like a QT interval, so we call it a pseudo QT prolongation. Also, P wave become tall. Now, tall P wave is P pulmonale, but here there is no R enlargement. We call it a pseudo P pulmonale. Other electrolyte abnormalities are hypocalcemia, hypercalcemia. So in hypocalcemia, calcium level decreases, so QT prolongs. In hypercalcemia, calcium level increases, so QT shortens. So these are only the ECG normalities in hyper and hypocalcemia. Now let us come to arrhythmias, tachyarrhythmias. So in tachyarrhythmias, there are two type of tachyarrhythmias: SVT, that is supraventricular tachycardia, and VT, that is ventricular tachycardia. So for your exam purpose, any broad complex tachycardia is a ventricular tachycardia, any narrow complex tachycardia is a SVT. Okay. Now SVT can be atrial fibrillation. So SVT means ki any tachycardia which is originating above the level of ventricle. So it can be atrial fibrillation, atrial flutter, MAT, focal atrial tachycardia, AV-NRT, it is AV nodal reentrant tachycardia, AVRT, atrioventricular reentrant tachycardia. Out of them, AV-NRT and AVRT, they are arising near the AV node. Okay. Also, very they have very sudden onset. So they occur paroxysmally. So AVNRT and AVRT are also known as PSVT, that is paroxysmal supraventricular tachycardia. Now let us look at this ECG. In this we can see that there is this broad complex and heart rate is almost 180 to 190. Okay. So this is a broad complex tachycardia. Morphology is same everywhere. So this is a case of monomorphic ventricular tachycardia. Like, treatment is, if patient is unstable, we give cardioversion. If patient is stable, we give antiarrhythmics like amiodarone or lignocane. Okay. In this ECG, we can see that this is again a broad complex tachycardia. Rate is almost 180 to 190, and the morphology of QRS is different everywhere. And this is forming a pattern like this. So this is case of polymorphic ventricular tachycardia, which is also known as Torsades de Pontes. Okay. Now let us look at this ECG. So in this ECG, there is no visible P wave. Okay. So in tachycardias like AVNRT and AVRT, which are together known as PSVT, since the foci is near the AV node, so P wave generally either merges into the QRS or comes just after the QRS. So in this, we are not able to appreciate any P wave. Why? Because it either merges into the QRS or it is occurring just after the QRS. Okay. And rate is almost 200 here. So this is an ECG of PSVT. Okay. Now for PSVT, what is the treatment? If patient is hemodynamically unstable, then we have to give cardioversion. So in any arrhythmia, if patient is hemodynamically unstable, cardioversion is the treatment. If patient is hemodynamically stable, then first thing that we will do is vagal maneuvers or carotid massage. Not controlled, we'll give adenosine 6 mg initially, then 12 mg, then 12 mg. If not controlled, then we have to give diltiazem or verapamil, which are calcium channel blocker. If not controlled, then we have to get a radio frequency. So I covered all the important ECGs that have been asked till now. and the ECGs that has the probability to get asked. So just try to understand them, try to grasp them, and you will definitely solve all the questions of ECG in exam. Okay, all the best.